Good morning. Thank you all for coming. I'm Erin Shaughnessy, the Division Chief of Hospital Medicine, and it is my great pleasure to introduce our Grand Round speaker today. Dr. Raj Srivastava attended the University of Toronto for medical school and completed his pediatrics residency at the hospital for sick children in Toronto. He completed a fellowship in health services research at Children's Hospital Boston. Currently, Dr. Srivastava is the Assistant Vice President of Research at Intermountain Healthcare, a large, not-for-profit organization that provides care for approximately 800,000 patients in Utah and southeastern Idaho at 23 hospitals and 185 outpatient clinics. He also co-directs the Intermountain Healthcare Delivery Institute, where he oversees the care delivery science team. Additionally, he serves as medical director at the Office of Research and vice chair of research, the Department of Medicine at Intermountain Medical Center. He is a professor of pediatrics at the University of Utah and a practicing hospitalist at Primary Children's Hospital in Salt Lake City. In addition, he serves as co-director of the Stanford Intermountain Fellowship Program. Dr. Srivastava is past chair of the only funded hospitalist network, Pediatric Research in Inpatient Settings, known as PRISE. PRISE is a research and implementation network of over 100 hospitals that conducts several large multi-center studies that are important to the field of hospital medicine, including the IPASS studies. Welcome.
Thanks, Sharon. It's a real pleasure to be here, and I want to thank those who took me out to dinner last night. It was really nice, and I really like how close you guys are to Salt Lake City, so it makes it easy to come and visit. So I'm going to talk about some ideas that I and a few others have had about how do we better design and deploy changes that we know have to happen in healthcare, and I'll talk about this journey going through pediatric examples that I have learned with a group of people that I've had the pleasure of working with through our PRISE network, and then go into, at the health system level, how we're trying to do this as well. Bring together that research, administrative, clinical needs, all focused on the same goal. So I think this is probably no surprise to anybody. We have a lot of challenges in healthcare delivery today. It seems that there's more disruption going on, there's more mergers and acquisitions happening, that, and the costs of healthcare keep rising. We still know there's a lot of waste in the system, so we want to take out that waste. And most importantly, we want to deliver what's best for our patients and the communities that we serve. This, on the top left, this challenge of we are in a fee-for-service world, or largely have been, but we're moving to a fee-for-value world. That's what I'm going to be talking about a little bit today. As in my hat with Intermountain, we have moved largely, or a big portion of our business is fee-for-value, and that has helped drive some of this behavior as well. So I got started with the Pediatric Research in Patient Settings Network about a decade ago, and it was a good group. You can see here on the right, some of those are newer folks who came in, but some of the originals, folks in 2008, Karen, Chris Landrigan, Samir Shah, Ron, Karen, Sanjay, we were there in 2008. And the idea was, this is such a great idea, because when you have a network that's academic, it's free. And so you just say, come join and we're going to do good things together. And of course, everybody wants to sign up. But then you're trying to decide, well, what are you going to study? And it turns out we had not had a dollar to our name before, really. We had never gotten a federal grant. We had never published together. Everybody there was an assistant professor. We had one associate professor. Phew, Ron. And so here we were, and the reason we reformed and took PRISE in this direction was the charge had been, we want to become a specialty. Well, now 10 years later, we are a specialty, and now some people have to take exams. I know I have to take exams too, I was telling Erin. And we also decided that we would not be all of us decided that we would just take the exam because we're pretty young, so we should be able to all participate in this and lead through this. So when we got together 10 years ago and we didn't have any money, the first thing we said was we need to have funding so that we can do some work that we think is really important. So who would you go to if you had a funding request? So you would go to your CEO. Turns out you would actually go to your CFO, but you could go to your CEO, and that's what we did. We just went to the CEOs of the largest children's hospitals at the Children's Hospital Association. And they were really interested because back in 2008, we were talking about, there were things like the Affordable Care Act was coming out, or at least being debated. And so people were talking about how do you drive waste out of the system? And we said, oh, no, we know how to do that. We're hospitalists. In fact, we spend all of our time in the hospital, and we see a lot of opportunities for improvement. So why don't you give us a little bit of money, and let's get this network going in this direction. So they funded us. And these were some of the original, this is the original work we did. We said, hey, we're going to use your data. We're going to prioritize your conditions based on, is it prevalent? Is it expensive? And are there a lot of inter-hospital variation in cases? So is this group treating hypoplastic left heart slightly different than this group? Or is this group treating asthma slightly different than this group? And then we'll just make lists for you. And the whole idea was to start a conversation between the administrators, operators who run healthcare systems, and the clinician leaders to say, if we want to agree to work on one thing, what would that be? So we prioritized these conditions and gave these reports out. I think last night I mentioned at dinner, this was actually the report from Primary Children's Hospital where I practice, and in the red means that condition we are spending the most resources compared to all the other children's hospitals in this database. There are about 3.5 million kids here over 6 years, and that particular condition that we're spending more, and it's adjusted for like hospitals and like patients, that condition was bronchiolitis because we had over-prescribed our quality improvement endeavor on that. And we'd forgotten sort of the principles of quality improvement and how you really only want to have a few leverage points, not 40 leverage points. And so, of course, that made the hospital a lot of money. And our CEO was like, whoa, wow, we're doing really well. And we're like, no. We actually should get the kids out of the hospital. And to his credit, Joe Mott said, oh, well, then get them out of the hospital. Why are we doing this? And so it was an interesting journey for us. But even when you produce reports, that just tells you resource utilization. If you spend more, that might be better. If you spend less, that might be better. You really don't know unless you have the outcomes. So then we did 4 studies. This is just one of the examples where we took 4 conditions. This is tonsillectomies, and we rank ordered all the children's hospitals where they were actually giving all of the quality measures or they were giving none of the quality measures. What are the quality measures? Every child should get a dose of, for routine tonsillectomies, same-day surgery, come in and out. Every child should get a dose of dexamethasone because it prevents the nausea and vomiting and coming back to the ER and needing fluids and or going to their PCP, et cetera. And nobody should get antibiotics because routine antibiotics don't actually do anything except cause C. diff. So this hospital was doing that 95% of the time. How great is that? This hospital, not so much. Well, these are like the largest children's hospitals in the country, and yet they have such wide variation in what they're prescribing for best practices. And then we looked at their outcomes because that's what you want to know. What's your 30-day return visit? So this study that we did had 10,000 kids. There were 250,000 kids who got their tonsils out. That's a lot of tonsils being taken out, by the way, in children's hospitals. And I think we just looked at the data as it existed, but of course then there's a question upstream. If you're fee for value, do you really need to take out a kid's tonsils? And we've known for about 120 years, because of the British studies, you mostly don't, but we still are. But then what happens to the 10,000 kids that come back? This is by hospital, their readmission and ED visits. I mean, I'm not sure what's going on over here, and I'm not sure what's going on over here, but I think I would really want to know if I had that data. And then, of course, the bleed rates, which are a serious complication. What are the differences in bleed rates across those 40 children's hospitals? And lastly, what's the spend? What are the standardized costs for each of those hospitals? And you can see here, this is the standardized costs, and these are buckets of time and the type of supply they use, how long they stay in the OR or the recovery, or the anesthetic agents. That's it. That variation of twofold is just those three things. So one of our surgeons at Intermountain, Jeremy, got super interested in this, and he said, Raj, I kind of want to know what the techniques are. And I was like, oh, we can't get that in this national data. So he did 8 studies, and he started looking at by surgeon what the variation was, and now this is Intermountain healthcare data. These are all 14 pediatric surgeons. He went on to do that for all 75 surgeons that operate in any Intermountain healthcare facility, employed, affiliated, adult, and pediatrics. Turns out there's a family practice doc who was doing several hundred tonsillectomies a year somewhere in Utah. And so he pulled their data, looked at their outcomes, and then looked at the costs. These are actually Intermountain costs. So you can try this electrocautery, which is $46, or you can try this awesome harmonic scalpel, which is $346. That's the cost. That's not the charge to the patient. And then he looked at all the same outcomes. Absolutely no difference. Then the surgeon said, wait a minute, if I use this, the parents go back to work the next day and the kids are happier. Really? So then one of our lead surgeons said, I'm going to get 2 nurses to give a standardized health-related quality of life instrument and give it to the next 2,000 families. So 6 months later, all that data was pulled, because we do 5,000 tonsillectomies a year at Intermountain. No difference. Okay, so now why are we choosing this, which is much more expensive, over this, if the cost, complication, family-related quality of life is no different? One of the other things we did in the network, as we were thinking about how to design and deploy, so far I haven't actually convinced you we've deployed anything, I hope. I'm just showing you what we were doing, describing the problems. I think we thought if we described the problems, people would just naturally come and want to solve them. Turns out that's not so much the case. So when you have administrative data, it's not the same as if you have clinical data. So we did this study to link all the clinical data to the administrative data, which would be much more powerful. So now if you wanted to say, hey, there are 2 or 3 different common antibiotic regimens for hospitalized kids with pneumonia, it would be really helpful if I could pull all of their chest x-rays if they had it, all of their labs if they had it, and if I could look at all of their cultures, and I could use those results to analyze, does antibiotic regimen A, B, or C, which one's better? So we did this large study as well. And then we started to say, well, I wonder if we can answer super common questions that as a group we've had, but we've never really answered together. And so this led to the PIVOT trials. And this was actually the first PCORI, the Patient-Centered Outcomes Research Institute. We were the first ones in the first batch to put some studies in. And then ours was amongst the first to get published, or to get granted, which was fascinating for us. And so what we did was answer this question, hey, there are common infectious conditions that land kids in the hospital, and they need, for, say, osteomyelitis, a bone infection. They might need to see infectious disease, depending on what we're trying to get down to our antibiotics. They might need to see orthopedic surgery. depending on the severity, they need some imaging, they need some care with our hospitalist team, and that's all legitimate. But then when we go to send them home, there's a question. Do you send them home with this peripherally inserted central catheter and tell the family to dribble in this medication a few times a day for the next 4 to 6 weeks? Because it's not like we really have home health that goes in and does that. We teach them to do that. Or do you just prescribe them a pill/syrup where the child just takes that every day for 4 to 6 weeks? So this was the first, a group, Ron, Karen, and a group had answered this before using the data, but they didn't have the results. And so, using sort of administrative data, I don't think that really swayed as many people. So we did this large chart review, actually, where we got this grant and we used the administrative data, but had the clinicians verify every case. Did they truly get a PIC or not? And then what was the treatment failure? Because we want to verify the exposure and the outcome. Turns out 1,000 kids naturally got a PIC line and 1,000 kids naturally did not. They got oral antibiotics. The treatment failure rate, the same with 1,000 kids. Now, I really like randomized controlled trials. To answer this randomized controlled trial with the treatment effect estimates probably would be about $25 million to run and take about 10 years. I don't think that's going to happen. I don't see NICHD or other funders being able to say, no, you're right, we should answer this trial. This, I believe, so far, this is the best we have. So we have to decide how are we going to change our practice. What happens today at children's hospitals when a kid comes in with osteomyelitis and has to go home? Are we putting PIC lines in, or are we sending them home on oral antibiotics? So this was a lot closer as we were figuring out how we're going to deploy another intervention. Oh, and it turns out parents don't really want a PIC line, not surprisingly. So this led to a group of us then thinking through how were we going to try things in routine healthcare that was actually going to change practice. So this is probably our giant experiment, which turned out, I think, worked, which is nice, which is why I'm telling you about it. But back in 2008, we recognized that there were a lot of changes in the healthcare system that needed addressing. One of them was we had a lot of problems in patient safety, and a lot of that was due to communication. Concurrent with this, we knew that back in the day when I was an intern, you'd stay up for like 36 hours, and I was making all kinds of mistakes. And so rules came down saying, you shouldn't really do that. You should actually get some sleep. Like when I got on the plane yesterday, I think the pilots were actually really well rested. I was very happy. And, but we didn't do that in healthcare. So when we did that in healthcare, what did we do? Did we add training? I don't remember that. Did we change the way we educate? I don't remember that either. But we definitely cut out a third of time. Okay, so now if we're taking out time in this one 36-hour period, a child who gets admitted can be looked after by 5 different teams. That's actually not that unusual. The kids are also sicker. A lot more is done on day 1, and they go home faster. So here's what we didn't do until we did this study, was we didn't have a standardized way we were handing off. We had different ways. So a group of medical educators and hospitalists got together and said, let's devise a way to see if we can discover and prove a standardized handoff works. And so we came up with IPASS, the illness severity, patient summary action list, situational awareness, and synthesis by receiver. Synthesis by receiver, still the hardest thing to do. I saw my last patient 3 weeks ago on Sunday, so somebody's signing out to me, and they're telling me this thing about sodium, which, by the way, is challenging because sodium problems happen 2% of the time in a children's hospital. Much more common in adults, but not that common in kids. And then they're starting to talk to me, and I'm thinking, okay, let me think about the sodium problem. So you're saying they have this disease, and I'm supposed to wait until they start to break through, and then I give them this drug, and then they stop, and then something happens to the sodium. I wasn't on rounds. I don't remember that. I have to reveal to the person signing out to me, I don't remember. Not easy to do in healthcare. Not when we're often judging each other by what we're saying or how we're arriving at our decisions. So this is hard. And yet, it's in the best interest of the patient, which is why we're here, that we do this all the time, routinely. And so, turns out it worked. It decreased harm to the patient. Okay. So now we know, this is the third thing we know in healthcare to do routinely to keep patients safe. The first was clean a central catheter a particular way. The second was have a surgical checklist. This is the third. Sign out using iPass in a standardized fashion. You will prevent harm to your patients. Super hard to do. And this was really great for us because we were able to get this out in the New England and then have a series of studies that have actually gone on. This is actually the latest study that was published. We also then said, wait a minute, so we know family-centered rounds as a concept is important, but we don't always have the nurses there and we don't always have the families there. I wonder if we could use iPass and bring the family and the nurses with the docs so we round together. So this was an extension of the iPass study, actually using family-centered rounds as the intervention, where the nurses would come and the families would come, and the family spoke first. Not the docs, the family. Living room language, no medical jargon. We actually had the Institute of Medicine, now it's called the National Academy of Medicine, really help us take out the, really follow the principles of health literacy. Because most of this was written at a grade 4 level. So we were talking to families for what they needed to hear. And so this also worked. It turns out if you follow this, you decrease your harm to the patients by 38%. First study that I know at a large scale that if you engage the family and you listen to them and act on what they say, you will keep your patients safer. Okay, hard to do because on service, we're kind of running around every minute of the day, and yet we have to stop, pause, listen. And by the way, that synthesis by receiver, that was the family telling us. So we had this dialogue. Can you tell us what you heard today? It's not a test of you remembering. It's actually a test of our communication. Yeah, we wrote some things on the board. You have your nurse here. We can talk, but if you're not able to reflect on what we just said, we've got to start over because that means we're not all on the same page. Okay, and this one came out in British Medical Journal, actually, in December of last year as well. So that's how we learned, or I learned with the PRIZE network, how we were going to better design and deploy. And then I joined Intermountain Healthcare, and I actually joined the Healthcare Delivery Institute. So Intermountain, it's this large not-for-profit health system, as Aaron was saying, and this is the scope of Intermountain Healthcare. It has its own health insurance plan, which covers almost 900,000 lives, looks after about 50% of the state of Utah. And the children's hospital, the flagship children's hospital, is run by Intermountain, but staffed by the University of Utah, the Department of Pediatrics. And that's where I started off in 2001 when I joined to help start the hospitalist program there. So Intermountain Healthcare reorganized 2 years ago. And this was how the reorganization landed. focus on the people, and there are two arms to the organization. There's the hospital-based arm, or called specialty-based care, or the community-based arm, community-based care, home care, home visits, primary care, everything to keep patients healthy and out of the hospital. Here, if you're sick and you need to come to the hospital, okay, but let's do it at the highest quality at the lowest affordable cost, taking out that waste. That's how Intermountain redesigned, and then this is our executive leadership team that's led, that'll show you a slide in a minute. So why did Intermountain restructure? This is why. Intermountain has two canoes on water connected together, okay? 1 foot in each. That connection has to be super strong, otherwise you're gonna fall in. Intermountain is now down to 60% fee for service for the entire system, 40% fee for value. January 1st, Intermountain's prepaid for 40% of the revenue and has to take care of the population, saying, we need to keep you healthy. Okay, how much of the research is caught up to keeping people healthy? Not that much. Now how much do we need that research to keep people healthy? Absolutely, because this makes so much sense. It's hard to do, and I've been at the organization, watch it going through this transition. But boy, once you open up that door, there are so many more things you can do to design and deploy. And I'm going to give you some examples. This is the executive leadership team. Mark Harrison's our CEO. Pediatric critical care doc by training, trained actually at Primary Children's, and then went off to the Cleveland Clinic and did a lot of great things there, and then came back to Intermountain a couple of years ago. My boss is Mark Briesacker. He's the chief physician executive of the entire medical group. So there are 1,600 APCs, or APPs, advanced practitioners. There are 4,000 employed physicians, and there's a few thousand affiliated physicians. The entire Department of Pediatrics at the University of Utah, affiliated. They're the largest group, and they practice at the Children's Hospital. And then here's the rest. You may have heard of some of these people. I'll talk about Dan at the end. We started a not-for-profit drug company. I'll just leave with that. Talk about disruptors. Why? Because pharma charges a lot, and we don't have enough generics, and we're running out of things every day. Or Mikkel Moore's project that she's leading on, we're investing in social determinants of health. $12 million to 2 communities given to the communities. Can you link the transportation to the food to the housing better and keep them healthy? So as Intermountain restructured, we then reorganized research and academics, which had never really had an official home in the organization. And so Todd and I actually get to lead the Healthcare Delivery Institute, and we're in that research and academics. And this is what we do. So we see whenever somebody wants to deploy something, please come to us to talk about it. Why? Because there's probably 2 components we think we could add. One is education. Do you need to train people on the principles of quality improvement and then get that team or army out there to be able to deploy in real time and troubleshoot? And so we have a advanced training program, and then as Aaron mentioned, we actually started a fellowship with Stanford. Why did Intermountain start a fellowship with Stanford? Because every day we are deploying in a population health environment. How many people are learning that? Not many. And so let's get physicians who finish residency but are not attendings and give them a fellowship where they get to live in Stanford for a year and learn how to learn about their master's in implementation science and health services research. And then we give them some mentoring, but then come back to Intermountain and work on these large deployments and help us learn how we're doing and how we could do it better. And train, if you want to be a leader in deployment going forward, learn how to implement better. Why not come into a project to do that? And then this is the other side, the evaluation side. And that's one of the things that I lead. So in our shop, we have applied health services researchers. We have health systems engineers or process improvement experts. And then the third is we have the biomedical informaticists, those people who can help with the tools. Those three skill sets, folks we have brought together to then work with our clinicians when they're thinking about what are they going to do. So in our training, with the advanced training program, we've had to change it, and we're still in evolution of changing it. I know some of you will come and see what that's like. But for example, telehealth. Why do people have to come to see us? Used to be because that's how we got paid. Turns out, if you do telehealth, now people are figuring out how to pay for it, but before, it's still a disruptor. Often I felt as a pediatric hospitalist, if I was looking at an adult ER and that ER doc called me and put the camera on and gave me vital signs, my training, I just do one thing, sick or not sick. I might not know what's wrong, but as a pediatric person, all I've trained to do is see a child and say, you look sick. And that's what a lot of our training is. On the adult side, not the same thing. So maybe there's a lot more uncomfortableness or testing or other things that have to happen, but imagine how they could connect with you. And you could say, wait, transfer the kid right now. Or after everything I've seen and everything, I'm not sure we would really do anything. Do they have a doc? Can they go home and see them the next day? So we have focused on these pieces as well as the Leadership Institute, our connection to the Leadership Institute. So we're the Healthcare Delivery Institute. The Leadership Institute is run by our third CEO, Charles Sorensen. So at the beginning, there was a beautiful building on my slide. That's Intermountain's answer to education, train physician leaders. So when Charles was retiring, one of the board member, Kim Gardner, said to him, you're going to retire and be a urologist at Intermountain, or you could still do some other things. And Charles said, no, I think I want to retire. This is a story I heard Charles say, so if I got it wrong, it's because he misspoke it. But Charles said, no, I think there's one thing I've noticed that we're lacking, to go through all the changes in healthcare, and it's physician leadership, that principle-based leadership to deal with the changes that are going to come, the changes we think we know and the changes we certainly do not know. And we need those group of leaders to be trained to get our health systems going to really focus on what's best for the patients. So we started the Leadership Institute for the not-for-profit health systems to train them. And then I already talked about the fellowship. One part of the fellowship I just mentioned, the second line, the day of strategy. So at the beginning I was like, well, fellowship, I did a fellowship, I know what fellowships are like. And then I realized, oh, no, this is just not any fellowship. So in this fellowship, our CEO reached out to me and said, hey, Raj, I'd love to see the fellows. Do you mind flying them in next week and we'll just spend a day with them? So the fellows flew in and had 2 hours with the CEO and COO of Intermountain Healthcare. 2 hours in a room. I was the only other person. What did they talk about? Strategy. Why is Intermountain going where it's going? What's the imperative? What are the things that they're interested in? The fellows had a list of questions, and they went through the list of questions. The CEO and COO prepped 60 slides. They got through 3. When I think back my own career, I think I would have wanted to be in the room where it happened. I would have wanted to hear, well, why are you choosing this way? How is that going to lead to better patient care? And then there were 6 more hours with all the VPs where they just went through and rotated. That's something that's going to happen every year because there should be clear visibility as a clinician between what you're doing and what the priorities of the organization are and the strategies. And what I realized was if that's not clear, that's the job of everybody in between or to make a direct connection. It is super helpful to know where you're working, where the organization is going and the why. we really respond as physicians to the why. And the more it's about the patients in the community, I think we respond a little bit faster. And then I think it makes decisions come down a little bit easier. Yeah, I understand. We have to save that money because at Intermountain, we gave $225 million to charity care last year. Oh, by the way, that was our operating margin. So 100% more than the operating margin went back to the community. That actually feels really good, knowing that people should not go broke if they get health care in our system, if they don't have those finances. So this is the shop, and so this is how we focused on our care process models. What are they? Certify them. By the way, we have never done it this way at Intermountain, and we started this last summer. We went from 100 care process models down to 2. Why did we do that? Because in the new structure, we have to prove when we come up with something, it's actually able to go across the system, the mothership and the rural facility. Otherwise, maybe the care is unequal, and that doesn't seem right. So certify that the evidence-based practice is ready. By the way, when you get a bunch of docs talking about that evidence, turns out not all of them agree it's ready, whatever the condition. But that has to be ready, and then prioritize it. What's the thing we're going to work on this year? We cannot work on 100. We chose 2. And then spread it and implement it. First test it, and then scale it, and then evaluate it. Here's my research hat. Let's prove it. If we say we're going to do it, we can totally prove it along the way. So these are the criteria that we came up with for prioritizing. Their key leverage points are identified. Not 40, 3. Maybe 2. That's it. That's what people have to remember. Do these 3 things. You have to have a measurement system. You have to have the strong evidence. You can see the rest of the priorities that we came up with. By the way, when you do this for all of healthcare, turns out there are not 10,000 things we should be doing. And of course, if we're going to do them, I want to make sure we're doing them well. So then we came up with this mapping. This is a tool that's commonly used by health systems engineers or QI experts, where you actually go through the process of identifying, organizing, who's going to work on the problem, experiment, develop, implement, and you put it in these rows of who's in charge. And here you have all the leadership listed on the left. So now when a project is go and is moving through, it has touch points to leadership multiple times, because executives' days are as filled as clinician days. They're just filled with different things, meetings, and they need formative reporting, summative reporting. They need to know, well, is it on target or not? If it's not, what's going on? But they're being hit with that 100 times a day, just like clinicians are being faced with 100 decisions a day about patient care. Okay, so this is an adult example of one of the 2 care process models. Turns out, and I think a lot of people would know this, if you think you're having a stroke, you should get to a hospital and you should get alteplase within a really defined period of time. At Intermountain Healthcare, that was not happening at our 23 EDs consistently. So this was the project we took on. We started this last summer. This project went live in September. This is data from September, from Q4 of last year. Okay? And by the way, it's all hand verified. Why? Because if we're making decisions on this, I think all of us want to make sure that it's not just a standard poll, that there's some verification. And our systems are difficult, and so we are getting better at the reporting, but we had to make sure we were going to really deliver. So what did we do in those 3 EDs? We picked 3 of them, rural, urban. They went from door to activation from 17 minutes to 10 minutes. 10 minutes is what the national societies say are best practice. They went from door to CT time from 20 minutes to 13 minutes. And then they went from door to needle time from 56 minutes to 50 minutes, okay? By running this to those 3 pilots where we're deploying, there were 4 patients who had better stroke care than they would have if we had not run that project. Not only that, at one of the community hospitals, there was an 8-year-old who came in who was slurring their speech and walking a little funny. The triage person said, "I think you're having a stroke." Why? Because we're running this large project on the adult side, and I'm allowed to activate the stroke team. So I'm going to activate the stroke team. And the parents are like, "I don't know, this is a stroke. This is like, kids don't get strokes." And so they activated the stroke team. That kid was in the OR at Primate Children's, life flighted within the hour. The kid was having a stroke. Actually had to have surgery, completely recovered. I've been at Intermountain for 18 years as a pediatric hospitalist. I've never seen a rural community hospital pick up a case because we're running a research project, except it's not a research project. It's actually better care. That was phenomenal. Here's our pediatric. We picked 1 adult and 1 pediatric care process model because we're a system. This is a PEDS-ER problem. Kid bonks their head. Parents are worried, bring him into the ER, and people are wondering, do you have to scan them? Well, in 2009, PCARN, the large PEDS-ER network, answered this question and published it in Lancet in 2009. They said, oh, well, you know what? There's risk criteria. Follow the risk, low, medium, high. Low, nobody needs a CT scan. High, everybody needs a CT scan. Medium, depends. Lots of studies have subsequently refined the medium. This is what our group, the biomedical informaticists, did to the electronic medical record. They altered it so it looks like the paper, and it actually has the risk criteria and the radio button. So if you hit the radio button, it goes right to the order set and gets ordered. Okay, there's no radio button for low risk. What did the docs ask for? An extra radio button. Because they're like, wait, I went through the whole thing and I just followed this. Oh, by the way, thanks, because I didn't remember all the PCARN rules off the top of my head. But if I do that, I can just discharge and the kid, like the nurse will go in and give the instructions to go home. So they wanted a radio button. As far as I know, that's the first case where the doctors in our massive EMR rollout that we've just gone through the last 2 years asked for an extra click. Click that's worth it, as opposed to all the other clicks that many of us don't understand why are happening. Here's what happened to the low risk. Turns out the avoided CT scans, we were only avoiding them, we weren't avoiding them all the time. Hand collected data within 3 months, we were avoiding them all the time. No low risk patients in 3 different ERs. The stroke, 3 ERs, we have 23 ERs. Stroke, 3 ERs, peds in 3 different ERs. Why? You cannot slam the same people with all these projects. And so we had to separate them. Okay, so what's the research purpose at Intermountain? It's to use our model health system that advances clinical investigation to improve patient outcomes, healthcare quality, through innovation, discovery, and implementation science. This map, I just want to let you know, 93% of Utahns live within 8 minutes of an Intermountain facility. A lot of that's urgent care, but imagine now you want to deliver something to keep somebody out of the hospital. And when they need it, you're super close. So this is what happens when clinical care and operations and education and implementation science overlap. This is what I think is what we're doing is a little bit of the promise. So we know for 30 years, if you're an adult and you get acute lung failure, you might get acute respiratory distress syndrome. Only about 25% of people get that. If you do get that though, and it's recognized, and you get early lung protective ventilation, you have a 40% chance of living. Your survival is that much better. Not 40% chance, 40% better chance of living. Okay, that sounds important. Oh, and by the way, you spend less time in the ICU. Now when you go home, we have so much better knowledge that people are wrecked by being in our ICUs for a long time on the adult side. They're delirious. They can't go back to work. They have, for all purposes, PTSD. And so we know if you can limit that, you can get them back to their lives better. At Intermountain, that's not done 22% of the time, that lung protective ventilation. It's between 6 and 8 cc's per kilo of predicted body weight. But somebody just sends the ventilator a little too low, they feel like they're suffocating, a little too high, they're beating their lungs, and they're going to have problems. So you just need to set it between a certain range. So we got together and said, okay, let's see if we can change the practice in the 18 ICUs that Intermountain touches, the 4,000 ventilated patients, of whom 1,000 will develop ARDS. As we did that, we started that. Turns out the NIH actually had a call to say, we want to set up centers of excellence, and we want to fund 7 places in the country that where the evidence is known, they're getting it to their patients faster on the inpatient side, heart, lung, or blood problems. We were so fortunate that we were able to be funded and be one of these groups. I actually kind of think Intermountain was made for this. It doesn't hurt having an extra $1 million to prove it. Oh, by the way, the money, it's not to fix it all. It's to use the implementation science frameworks and figure out the barriers and facilitators for why people aren't doing it. And then we came up with a pilot intervention to change 3 ICUs. Because the strategies in one ICU might be different. Turns out the docs are different. Turns out they came from different styles or practices, and there's local culture. We have to get to all of that in a year. Also, we moved up our timeline by 3 months. So we're actually deploying in July. We were on the call with the NIH, and they were like, oh, wait, what do you mean you're moving up by 3 months? Nobody moves up by 3 months. And I laughed, and I said, well, we do here. Why? Because I know there are a few hundred patients that we could help faster if we just do this. So that's what we're going to do. Okay, what's enough? So I'm just going to leave you with our last example, antibiotic prescribing. Let's improve antibiotic prescribing. We talk about this all the time. So turns out Intermountain went to the CDC and made a commitment saying we're going to help our antibiotic prescribing, we're going to improve it. Okay, so how did Intermountain decide they were going to do this? Turns out there is a whole area of healthcare that is so sorely under-researched. Urgent care settings. Do you guys have urgent care settings here? Okay. So urgent care, after hours care generally, or get this, in the day because you can't go see your doctor, so go here. That doesn't make a lot of sense for continuity, but I understand its access. Well, Intermountain has 32 urgent care centers for adults and 6 for kids. The adult ones actually see kids if you can't get into the kid one. So 38 urgent cares. There are 700,000 urgent care visits a year at Intermountain. Kids and adults. This is a whole system study. 41% of them get an antibiotic. It's justified every time, right? Really? Because I was an urgent care doc for 7 years, and it's a struggle seeing 36 kids in 5 hours and then having to talk and say, oh, it's sinusitis, but I don't need to give you antibiotics. It's so much faster just to give it. By the way, I was getting paid for it. And by the way, now if I say no, my satisfaction scores are going to go down. Oh, and I'm going to keep everybody else waiting, and I'm going to get yelled at. But it's the right thing to do. So we got a grant from the CDC. It's actually a contract to come up with what are the baseline antibiotic prescribing practices and then come up with a bundle. The CDC actually has a bundle of core elements. we're gonna play around with it. We're gonna experiment. We're gonna figure out how do you deploy it in urgent care. And then we actually, the University of Utah has urgent cares, and they said, we're not interested in being the study. We'll be your control group. Wow. Now we have an interrupted time series analysis with an external control group to say, what happens when you deploy it and what happens when you don't deploy it? Now we'll know if it works. Okay, so I think this principle, organize everything around the frontline work processes. If we're doing it in a room, we're wrong, unless the frontline people are in the room. We're giving them the skills, we're teaching them. They know the processes. They know when there are no processes, and then they can help define that. And I think quality improvement is the science of process management. This is Intermountain Healthcare's research strategy. Why? Brent James, who was my mentor and hired me into Intermountain, and Greg Polson, they wrote this article in Harvard Business Review about why Intermountain's 40% at risk and how it's learning to run the business that way. And then the first year Mark Harrison came, Intermountain gave $900 million back to the community that year. I'd leave you with two thoughts. One, how do you get to prevention research? So we know social determinants determines more than everything we do in the hospital. We touch about 10%. This is about 60%. The research behind this, it's not very strong, but it is so needed. So Intermountain gave $2 million to 2 communities this year and will do so for the next 3 years. So $12 million. Link transportation to food to housing for Medicaid patients in our insurance product. Bring that community together, say, you're on the front line, you know how to do this, let's try to get that care better. Why? Because social determinants are health. If you're trying to keep people out of the hospital, maybe if the child has asthma and they don't actually have housing, or they're infested with something else in the area that's triggering their asthma, that's actually the bigger problem. But we're spending all the money in the hospital. So let's give it to them and see if we can change that. So this is an experiment we're trying to figure out how to do. And then the last one I just wanted to leave with was Civica. Intermountain's answer to disruption was what I would say, for Dan's idea, start a not-for-profit generic health drug company. Nobody makes money here. It all goes to run the business to get the drug price low and deliver it to the 1/3 of hospital systems in this country that have signed up or want to sign up to join. Because pharma isn't coming down on their prices. So instead of waiting for them, why not just take it in our own hands? Okay. Well, thanks for your time. And I hope it was helpful to learn about how we're designing and deploying in healthcare. Thanks.
I think we have time for 1 or 2 questions. Do folks have questions? Go ahead.
Can we in Arizona get into that pharma?
Civica?
I think that's a great idea. It just doesn't seem right to have all these big pharmaceutical companies trying to make profits for shareholders when health should be a public good. So that's a great response to it, and I can see something like that taking off. And I'd love to see you guys succeed, and maybe sell drugs to people in Arizona too.
Yeah, if you want to send me an email, I'd be happy to connect you to Dan. Your system may have already said they want to sign up. I remember Dan told me the story that the day they announced, then they called the FDA and said, okay, we're going to have to get these things through. And the FDA said, okay. They said, listened, and they said, well, normally this process takes this period of time. We're going to get to you an answer by Friday. And the answer was yes. Why? When was the last time the FDA had somebody not hitting them over the head or trying to beat them up or saying, you're so slow, push my stuff through for our profits, but saying, my interpretation, if you're doing the right thing, I actually think regulators want to help. Yeah, so if you want to connect, I'd be happy to get you guys with Dan. Again, you guys may already be a part of it or want to be.
I have a question. I'm just wondering, for clinicians in the room, what are one or two takeaways, what we should be doing every day in our inpatient setting to improve quality, safety, or value?
Yeah, great question, Erin. So I remember in my training early on, I used to think everything I was doing was helping the patient. And then people started studying a whole bunch of things, and it turns out not everything I was doing was helping the patient. If I could implore people, I would say I would try one thing. I heard you guys have recently picked up bypass, and you're trying it hospital-wide. By the way, that is really hard, so I applaud you for your efforts. I've gone around the country and talked at a lot of places. Here's what you can do. Take that on. Own it. Every shift, every time. Why? Because you're going to be on the receiving end, or your loved one's going to be on the receiving end of healthcare one day. You pretty much want those providers to be doing that same thing. So I think if there's one thing I could say, by the way, by doing this, we happen to have the best evidence out there. For every 100 admissions, you will save harm to a patient. One. That's worth it. That means every week, you guys are saving one patient. So that's what I would suggest.
That's great. Thank you.
Yeah.